Good afternoon, everyone. Thank you for joining us for this very informative webinar on pre-transplant. Let's give it a couple more moments just so we can let people log in and get comfortable. And we will be starting shortly. Okay. So my name is Karen Bertozzi. I'm part of the programs team at Mended Hearts International, and I'm very happy to present our team tonight on pre-transplant, what patients and families should expect. One of our very own members of our team and a heart transplant recipient, Glenn Kelly, will be taking over as your host this afternoon.
Great, thanks, Karen. All right, so good afternoon, everybody. I'm very excited to share our guest with you today and presenter, Dr. Dmitry Yaranov. I'd like to share with you a couple of housekeeping points. Everyone today is in listen-only mode. You won't be able to ask, we'll not be able to answer any questions related to your specific condition. However, feel free to ask away with questions. There's a Q&A box that I'll monitor and we'll answer those at the end of the presentation. The webinar is recorded and will be available on the Mended Hearts website and our YouTube channel. Further, we really took an initiative earlier this year to provide a home for transplant patients. And it's a resource center is what it is. It's our new program that we're launched, and this is literally the first webinar for the program called Empower Transplant. And this program currently focuses on heart transplant. We're able to bring this to you by two wonderful sponsors, Natera as well as Abbott. And in that resource center, you simply go there. You can go to mendedhearts.org/empower-transplant. No need to write that down now. Anyone who's registered will get a link to that site. In addition, you'll get a link to preparing for a heart transplant. That's a discussion guide that's digital, and it's a simple trifold and meant to guide you in discussions with friends, family members, your physicians. Great questions to ask. We have a repository there. There's currently 3. Here in the next couple of months, we'll probably have another 3 or more in that as well. We'll have other future webinars will be hosted, and those will also be linked in that site. So just a great resource center for heart transplant recipients. So on to today's session. Dr. Dmitry Yaranov is just one of the really leading voices in advanced heart failure and transplant today. I'm just tickled to follow him on social media. If you're not familiar, he's got quite an active following as heart_transplant_doc. And I got to know him through some of the policy work that we did together on the heart transplant committee for the OPTN, developing the statuses and policies and things that help really bring equity and fairness to heart transplant nationally. So without further ado, I'm going to turn it over to Dr. Yaranov. We're going to switch screens so he can drive his slides. I'm going to stop share. All right.
All right, well, let me share the slides and make sure that they work. We go in presentation mode and make sure that start with slide number 1. Just let me know if you can see the slide in the presentation mode.
Looks great. Go right ahead.
So I first thank you very much for the kind invitation and introduction. I'm very excited to be here. Thanks for talking about the social media, and I'll quickly tell you that we do know that most of our patients actually search a lot of information about heart failure and heart transplant on social media. A lot of times it's very important the source they're going to. And that's why when I got this invitation, I was very happy to spend some time tonight with you to give you an idea how I see this and how a lot of physicians in my field see that. So I made sure that I put a slides knowing that I'll be talking to the patients. So if you're a medical professional joining me tonight, make no mistake, this is going to be I'm going to try not to use medical lingo explaining everything we do. You'll see a lot of medical lingo in the slides, but I want to make sure that every slide is broken down to the point that once you leave it, you understand what I'm talking about. So if there's still questions at the end, please feel free to key them in the Q&A session. I'll make sure we'll leave enough time to discuss it. So who I am, I'm a transplant cardiologist. Sometimes they refer to me as advanced heart failure cardiologist. Sometimes they will tell me I'm a heart failure cardiologist, not just advanced. And all I do is I had a specialized training after general cardiology fellowship to take care of patients with different stages of heart failure. Patients who are at risk for heart failure, all the way to the patients who are in need of advanced therapies, namely heart transplants or heart pumps. And the goal today is try to simplify that journey to the point is if you were told that you need a heart transplant or you've been told that you should be considering a heart transplant, I'm going to hopefully explain to you what's going to happen with you next and how this journey can be convoluted. So I'm going to talk to you about the reasons to have been referred for heart transplant evaluations. We'll talk about those who are still debating whether they need a heart transplant or not. And I also will talk about the indications for heart transplant. And also I'll spend some time on contraindications for heart transplant. I'll tell you how we make those decisions, and I'll talk to you about some breakthroughs in a heart transplant that we have right now that help us get more patients to that solution or to end organ intervention. So heart transplant has a very long history, especially in the world of advanced heart failure therapies. And Lauer and Shumway were the first one who reported the successful experiment orthotopic heart transplant back in 1960s. I'm sure those of you who already searched heart transplant seen those Time articles where this was the first reported. Turns out that the first successful heart transplant, the surgery itself was successful. Unfortunately, what we learned, the patient did not do well afterwards because patient experienced rejection. And the history of heart transplant was very stagnant for quite some time. Here's what I summarized on this slide. There were several breakthroughs through the time of medication and mainly so anti-rejection medication inventions that led us to where we are right now. And you can see that in the 1960s, when we started talking about and doing those procedures, they were very scattered, single procedures, we learned a lot. Heart transplant was not widely accepted up until 1980s, where in 1980s, we developed cyclosporin. Cyclosporin really revolutionized the approach in patients in need of heart transplant. Cyclosporin is anti-rejection medicine that helped a lot of patients after successful surgical heart transplant actually start surviving for years and years after the procedure, because we learned how to suppress your immune system as such so your own immune system does not reject a very good brand new heart that can do a lot of good for you in your life. And you can see that nowadays we have quite a few newer generation anti-rejection medications. And we can take upon sicker patients whose immune system is very, very active, and support those patients through the years and making sure that the hearts do not get rejected. So this is the data. This is a graph that I pulled from an international registry of heart transplant recipients. And what's important to learn, and that's a lot of times I learn in social media, that there is still a misunderstanding of how long will I live after a heart transplant. Every time I see a patient who is considered a heart transplant as therapy, I always tell them that heart transplant is not a new heart forever. Statistics go that 50% of patients around the world will survive at least 13 years after receiving a heart transplant. What this means in statistical language is that unfortunately less than 50% of these patients will survive less than 13 years, and another 50% will survive more. Okay, so today in my practice, I do have patients who are over 30 years after a heart transplant. As you can see on this slide, that obviously this is not majority of the heart transplant recipients. And I do have patients who are very sick, and although they gain the benefit of a heart transplant and live several years after, they don't reach that median survival of 13 years. But if I tell you statistically, 50% chance of surviving 13 years after, that is quite a benefit or quite an adjustment, quite an addition to someone's life who is actually experiencing what we call advanced heart failure. So in this country, as I told you, or around the world, nowadays we're doing more and more heart transplant. But what we did in the last 20 years actually was not necessarily an expansion of the heart transplant therapy. If you see on this graph, anywhere from 1990s, when we developed one of the latest immunosuppression medications, the amount of heart transplant around the world and in this country actually plateaued. And that plateaued up until 2012, 2014, when we started seeing more and more heart transplant being offered. A lot of this in relationship to donor availability and also type of techniques we use nowadays to get patients to the donor heart or donor heart to the patient. And I'll show you some cool pictures of those techniques at the very end of this presentation. So now remember, I told you that to get a heart transplant, you need to be very sick, but also it has to be a balance. What we need to know is that your heart is very sick, but the rest of your body is strong enough to go through this high-risk surgery. Why is this important? Well, it's critically important because obviously if the rest of the body is not recoverable, the rest of the organs are not survivable, we will not be able to get you through the surgery. And if the rest of the body gives up, then what's the outcome of it? No good outcome can come out of this. And the third most important thing is that, let's say if your heart is sick enough to go through it, the rest of your body is strong enough to go through it, then we need to know that the lifestyle that you're living, and I'm not just talking about lifestyle in general, I'm talking about that you will be able to continue to take care of this gift of life that a lot of time is donated by to us by others. So I'm going to get you through all of those three parameters, how we determine those journey a little bit easier. So I took this slide directly from the guidelines. Here's the indication for why would you ever need a heart transplant. I'm going to try to break it down to make sure that we understand what are those indications for someone to undergo this procedure and surgery. Refractory cardiogenic shock that requires inotropes or MCS. What this means is that you are in the ICU. You either had a heart attack or you have a chronic heart failure for a multitude of reasons. But now you need to be in the ICU because a lot of your vital signs are heavily dependent either on machine. This machine can be a balloon pump, can be an Impella. We use different words for it. Or you're dependent on an IV drugs that keep your blood pressure up and keep your heart beating. A lot of times, sometimes you can be on those drugs at home. We call them inotropes. You may recall the names milrinone or dobutamine. And a lot of times, some other drugs that I'm referring to, you can only be on in the ICU. That's essentially what it means to be in the cardiogenic shock. Now, if you're not that sick, but you still have a very advanced symptoms, and we use the scale and call NYHA. I'll go into details on the next slide what this NYHA means. A lot of times you would be offered a heart transplant while you're still in the outpatient settings. And I always tell my patients, the best time to talk about heart transplant is not when you are in the ICU dependent on those inotropes or mechanical support, but the best time is to have this conversation while we're still in the clinic to be ready and prepared. If you're experiencing recurrent ventricular arrhythmias like ventricular tachycardia, your ICD keeps going off on you, and you've had multiple ablations or you're receiving multiple anti-arrhythmic medications to quiet down the arrhythmia, this a lot of times will be an indication for a heart transplant. If you have a congenital heart disease and you experiencing end-stage heart failure despite all the surgeries and therapies that you received, that's another reason why we would consider someone for a heart transplant. And another group of patients that sometimes get missed from all of this is those patients who continue to have chest pains despite every attempt to fix the blockages that are usually causing this chest pain. Most of those patients will receive CABG or bypass surgery prior. They'll receive multiple stents and will be on multiple medicines to help with this chest pain. But because this chest pain is not responsive to oral medicines, and you can only get better with IV medicines, most of the time those patients will be considered for heart transplant. So let's get a little bit more medical for a second, because every time I go and talk to general cardiologists who take care of the most heart failure patients in this country, I give them what I call a mnemonic. And that mnemonic is called I need help. This abbreviation we use for our general cardiology colleagues. And if you haven't seen the most recent post that I just posted on Instagram, just trying to explain what exactly that stands for. And here's what in medical jargon it stands for, and I'll break it down for you not using a medical term. I is inotrope. Those are IV medicine that keeps your heart going. You're at home getting those IV medicine through a pump. That's not a durable solution. It's not going to make you live longer. It may make you feel better. And YHA symptoms. Again, I have a slide coming up. What it means is that you're experiencing symptoms at rest or with minimal exertion. You're getting out of shower and you're getting short of breath because of weakness in your heart. That's usually not a good thing to have. Some of you get used to it. That's not a good thing to get used to. It's not going to get better. It's only going to get worse. E stands for end organ, meaning that other organs in your body start suffering, whether it's a liver, whether it's kidneys or any other organs, but we start noticing the damage that's happening to those organs. E stands for ejection fraction. If your ejection fraction is less than 20%, a lot of times that means that you fail to respond to regular medicines to improve that ejection fraction. And that is the time when we start talking about more advanced therapies. D stands for ICD shocks, defibrillator shocks. H stands for heart failure hospitalizations. If you get more than one heart failure hospitalization in 12 months, that's usually a red flag for your primary care, for your general cardiologist, for someone who deals with what I deal with. And a lot of times, this is the time when we'll start bringing advanced therapies. Lower blood pressures, you can't take Entresto anymore. We have to start decreasing the dose. Or I'm starting you on carvedilol and your blood pressure goes low. Unfortunately, that's a bad prognostic sign. Lots of times, this is the time when we'll bring up a heart transplant or advanced therapy to the table. And then prognostic medicines, all those good medicines that your regular doctor starts you on. Again, Entresto, beta blockers, carvedilol, spironolactone. All of those medicines sometimes will have to be pulled back. And sometimes I'll hear, well, they took me off this medicine. And a lot of times when they start taking you off those medicines, that's when we start getting very anxious and worried about it. How do we score it? How do we assess it? I already mentioned several times, we use different classifications to understand at what stage of heart failure are you in. The oldest one is NYHA. What NYHA means is it's a New York Heart Failure Association class. So New York has a Heart Failure Association, and back in 1980s, there was a big group of researchers and doctors set together and say, hey, let's make sure we understand at what stage of heart failure our patients are. How are we going to do this? Well, let's ask them how they feel and how much activity they can do and how much limitations they have. And that's where those 4 classes came from. If you are active on your My Chart, you pull up your cardiologist note, a lot of times you'll see this NYHA next to your diagnosis. NYHA 1 means that irregular activities do not cause any symptoms for you. Class 2, it means that the moderate activity causes symptoms for you. Class 3 means even mild activity causes symptoms for you. And then class 4, which a lot of times will be assessed as the end stage, means that at rest, you're experiencing symptoms related to your heart failure or weakness of your heart. ACC and AHA, which is American College of Cardiology and American Heart Association stages, are more related to your disease progression. Those stages only can go from A to D, A, B, C, D. A means you're at risk for heart failure. B means you have structural problem. Your heart is weaker than it should be. You have a leakage in your valve that can predispose you for heart failure, but you still don't have any symptoms. Stage C means is that you start having symptoms. You're seeing a cardiologist, you're seeing a regular primary care doctor, and they're addressing your symptoms because your heart is weaker or stiffer. And then stage D means is that your symptoms are so bad that they label you with end-stage heart failure, and they're sending you to see someone like myself, an advanced heart failure cardiologist, to be considered for advanced therapies. More advanced classification that you usually don't get to hear much, but that's a lot of times how we decide who gets certain priorities on the transplant list, is classification for end-stage heart failure. It starts from you being at home experiencing symptoms at rest, going through needing IV therapies or IV medications to keep your heart going at home continuously, getting them in the hospital continuously, and inner max by the name of the society. And this will tell you and specify the disease progression and how sick you are, how to determine who is sicker out of the sickest patients. So how do we determine who needs a heart transplant, who is at what risk while determining the need for a heart transplant? We usually like to think about three distinct groups of risks. It's a medical risk, usually determined by your medical team. It's a surgical risk, usually determined by surgical team, the surgeon who's going to do the actual heart transplant. And the third risk is a social risk, making sure that everything else is in place for you to succeed with a heart transplant after. So a lot of times I get a question, what are you doing as a cardiologist? You don't do you don't do surgery. No, I don't do a heart transplant surgery. Sometimes I assist in that surgery by doing some imaging during the surgery. But what I take care of is I take care of patients like you before heart transplant and forever after the heart transplant. While you're in the ICU receiving a heart transplant, while you're recovering after a heart transplant. Surgeons are the ones who actually do the index procedure of the heart transplant. You will see them several times more for a follow-up, and likely you will never see them again. So that's why we work in those teams that help us tag team, making sure you're taken care of on pre and post side. So where do we start? Every time I get a referral for a heart transplant, I start with simple things that I need from my referring colleague. I want to know what your body size is and what your blood type is, because this will determine a lot for me. I want to see the recent echocardiogram. I want to see how dilated that ventricle is, how weak this ventricle is, what other things I can do before even jumping to things like a heart transplant. I want to perform a very particular procedure, cardiopulmonary exercise testing, and I'll spend some time talking to you about it today. And also I would want to see most recent right and left heart cath, and there's high likelihood that I will be repeating that right heart cath once you come to a transplant center. So let's go one by one. Why blood type is so important? Well, blood type is so important because we will be putting you on a wait list, and your weight a lot of times will be hindered upon what type of blood group you have. What you need to know is that since O blood type is a universal donor, finding hearts for someone for O blood type is most difficult. And AB recipients are the easiest to find donors, so they're universal recipients. A lot of things come into play. Let's assume you're extremely sick by the time you arrive to see me, and you're blood type O, and I know that I'm out of time to find your heart. A lot of times our discussion will be very different compared to someone who's an AB blood type, and I will spend a lot less time finding you a donor. What is cardiopulmonary exercise test? I see patients across the 4 different states. And unfortunately, this is a very sophisticated technique trying to understand how weak and sick your heart is. And most of the regional hospitals do not have access to a test like this. That's why a lot of times you'll have to travel to meet me at my center for this particular test. I refer to this test as an exercise test. Although you see a treadmill here and you see a bicycle here, this is not a conventional stress test. Here, the goal is not to stress your heart to see if you have blockages. The goal here is to gradually exercise you to imitate what you're doing at home or what you're doing when you go out and about for your regular routine. and at the same time measure the oxygen and carbon dioxide exchange to get an idea if your heart with exercise can deliver enough oxygen to the rest of your body. Every time I make someone exercise on the bicycle or on the treadmill, I'm looking at several very sophisticated parameters at the gas exchange, but also I'm looking at a very few very simple parameters, like how long can you exercise for? Believe it or not, every time we're looking at a study of survival of someone who has heart failure, the longer you can exercise, the more rigorous exercise this is, the more you will live. The less you can exercise, the less you will live. And that correlates with what we call mortality. We know that survival of someone who doesn't exercise a lot is a lot less who can exercise longer. And the second parameter is also, I always ask our patients, what was the reason for you to stop? And a lot of times the answer that I hear, well, it wasn't my heart, it actually was my legs because they gave up on me. It was my muscle. It was muscles that gave up on me. So you have to remember that the heart is the pump that supplies oxygen for everything in the body. And once you start exerting yourself, if you don't get enough oxygen in your lungs, lungs will tell you to start getting short of breath. Yes, you are getting short of breath in your lungs, but this is the way your brain is telling you that your heart is not delivering enough oxygen. If you're not sending enough oxygen to your legs, you'll cramp up, your legs will get weak, or your legs will give up on you. So that's another reason how your heart and your brain are telling you that your heart is not doing a good job. So this test is extremely important. A lot of times based on this test alone, we can make a lot of judgment calls for the prognosis. The second type of test that a lot of times we will do is a special heart cath. A lot of patients who are dealing with heart issues, by the time they see me, most of the time, they will have what we call a left heart cath. The left heart cath is a type of cath where they give you dye, they go through your groin or through your wrist, and they're looking if you have any blockages. And if you get blockages or you see blockages during that cath, you likely will get a stent or you will be referred to a heart surgery to improve the blood flow to your heart. The right heart cath usually is not done until you get to later stages of heart failure or you have other conditions that can't diagnose with right heart cath. This is a type of heart cath that a lot of times we're going to go through your neck, and a lot of times you'll be awake. It's a very painless procedure. It's a very fast procedure, and preparation a lot of times takes much longer, but it gives us a lot of information, not just about how your heart is doing right now, but what's the likelihood of you surviving the next year in this condition, and also if you are a good candidate for heart transplant or not. A lot of times from this type of cath, we will learn that your heart pressures are high, and so are your lung pressures. And if the lung pressures are out of proportion to heart pressures, most of the time, this will be a contraindication for a heart transplant. So at that stage, we're still learning a lot about you to make a judgment call if you can succeed with a heart transplant in a given condition. A lot of my patients ask, will I be put out for this procedure? And I'll tell you that the most time, the answer will be no, because your lung pressures, when you're asleep or once you're under anesthesia, can go down. And if they falsely go down while you sleep on the table, I'm doing this cath, and then you receive a heart transplant and wake up and your pressures shoot up, a lot of times there'll be a big problem. So we always like to do this procedure while you're awake under local anesthetic, lidocaine, and it's no different than going and fixing your teeth most of the time. So after I got all of this testing, I get involved my multidisciplinary team. As some of you already know, I'm not the one who makes the decision. The surgeon is not the one who makes the decision. And the patient ultimately is not the single person who makes the decision. It's usually a multidisciplinary committee that gets together after they get all the data, they talk through the case and make sure that everyone is a specialist in their own area and want to attest to the fact that A, you're sick enough to need a heart transplant. B, that the rest of your body is strong enough to succeed with a heart transplant, and that the support system and social situation is in place to succeed with a heart transplant long term? And if not, how can we change it or help you change it to make sure that you can succeed long term? I'm just going to give you an example of how my transplant committee looks like, because it varies. Some parts of the transplant committee are always constant. Some of them can be different. But you always have a cardiologist, and you needed 2 cardiologists to evaluate a patient. You always have a heart surgeon who will do the transplant. You always have a lung doctor to make sure that lungs are strong enough. You have a kidney doctor who a lot of times is involved in a transplant, making sure that kidneys are good. And sometimes you may need a kidney transplant on top of a heart transplant. You need an infectious disease doctor because you will have immunosuppression after, and it will predispose you to a higher risk of infection. You need a blood doctor. You need a pharmacist to make sure that medicines are straightened up and you will succeed with medicines after. You'll see a lot of nurses, highly specialized nurses that a lot of times will be referred to as a coordinator. Those are transplant coordinators. There's social worker, there's psychologist, there's supportive care personnel, palliative care personnel, there's a dietitian, there's a physical therapist, and a lot of financial coordinator to help us navigate the insurance landscapes to make sure that you don't end up with a big bill after a heart transplant and all your medicines are covered afterwards. So based on the committee, once committee gets together, we determine what are those patients who we cannot transplant, or those are the patients who we should not transplant. And I'm going to walk you through major contraindication for a heart transplant, which you may encounter during these evaluations. Remember, I already started telling you about this lung pressures on the right heart cath. If you have pulmonary hypertension, which a lot of times referred to as a high pressures inside your lungs, a lot of times we'll use this abbreviation PVR, or pulmonary vascular resistance. So ultimately, someone undergoing a heart transplant alone, and the new heart that goes into the chest and gets connected to abnormally high pressures in the lungs will experience devastating consequences of a transplant. Right ventricle or right side of the heart will give up immediately. So certainly patients who have a very high pressures in their lungs or pulmonary hypertension will not be offered a heart transplant alone most of the times. Other solutions can be used in this case. Sometimes you can go for dual organ transplant, which I'll be frankly honest is rarely performed in this country or around the world because it's a highly complex procedure. Sometimes things like a left ventricular assist device or LVAD will be offered to help resolve pulmonary hypertension before you can get on a transplant list. But most of the time, this condition needs to be treated prior to considering a heart transplant. A lot of times, if you are older than 70 years of age, and this number varies from program to program, but 70 is a lot of times across the board is consistent numbers. We only can carefully consider it because most of the time, if you're older than 70 years of age and you have a devastating end-stage heart failure, it's very likely that the rest of your body already suffered damage to the point that most of the time you're not going to do well with immunosuppression and won't be able to deal with consequences of heart transplant. And a lot of those patients will not be able to receive those. But again, it's center specific, but majority of the patients that get a heart transplant are usually younger than 70. If your body mass index is more than 35, this will be a lot of times a contraindication for a heart transplant, mainly so because we've done lots of different studies. And if your body mass index is high, you will experience a lot of problems with healing of the wounds, especially on top of receiving immunosuppression. A lot of times you'll have a lot of complications after, especially your lung complications. You'll be having a lot of hard time getting off the ventilators. So several candidates can be carefully considered, but most of the time patients are not going to be offered a heart transplant in that point. If your BMI is extremely low, if your body mass is very low because you've experienced a lot of issues with heart failure, you can't eat your vomit. So a lot of times heart transplant is not a good choice in this case because again, you're likely not going to recover after a heart transplant in this situation. Other options can come or be offered at that point. So history of cancer, if you have a fresh cancer, the one that just got resolved, most of the time, the rule also depends on the type of cancer, but you want to be cancer-free. And here is why. If we were to give you immunosuppression, cancer cells are going to go crazy and start multiplying, especially if you have an active cancer. Those patients are not going to do well with immunosuppression. You're not going to succeed. And unfortunately, we will just make the situation worse. Diabetes, especially uncontrolled diabetes, if I give you prednisone, which is one of the immunosuppressant I give you after, your diabetes is going to get even worse and you won't be able to heal your wounds. And a lot of times your bones are going to get weak and you will start breaking them. It's not going to be a good solution. Again, other options will be offered like left ventricular assist device. If your kidneys are extremely weak, you're likely not going to get a heart transplant alone. You will likely need a kidney transplant on top of it. And if you're not candidate for both, a lot of times, again, left ventricular assist device in this situation will be offered. If you have real bad blockages in your brain or in your legs, those need to be looked at or fixed before. But a lot of times, if those blockages are unfixable, that's another reason why heart transplant is not going to be a good idea. If you're actively smoking, we've done several studies, you likely will end up with a terrible fungal infection in your lungs and die within the first 6 months after heart transplant. That's why we want you to be smoking free for at least 6 months before we will proceed with a heart transplant. And certainly, if you have any other substance abuse situations, we want to treat this before you undergo a heart transplant. You want to make sure that you are free of substance before you get put on the transplant list. Psychosocial issues is a very broad term. A lot of times nowadays, we want to make it a yes. What I mean by this is that we have so much support ready for you that if we identify a problem, let's say you live in more than 3 hours away from my center, most of the time we will be working on helping you set up a transportation or help you with transportation to get to the center. If you don't have a healthcare, giver, a lot of times those things can be worked up. That's why we have social work on our committee. That's why we have psychologists in our committee. So those people in those supplemental services can help us overcome those psychosocial barriers. So another ones that I'll tell you, if your lungs are damaged to the point that you're on oxygen, most likely you won't be able to receive a heart transplant. If your liver is damaged to the point that liver is not working anymore, again, heart transplant is not the right thing. You're not going to wake up from that surgery. And obviously, if you have an active infection, that infection has to be treated before you get a heart transplant. I know it sounds like a lot, but I just wanted to be more inclusive to make sure that you understand why sometimes the answer is going to be no. And although most of the time, all the no's are relative, sometimes we will reconsider this as we treat those problems. But that's the reason why a lot of times committees will say no. Once you get a yes and you get on a heart transplant list, our transplant list is arranged in priorities. We know that those patients that are sicker, the ones that are sitting in the ICU, the ones that require a pump, the ones that require an advanced support, likely not going to be able to wait the same amount of time as someone who is at home waiting for a heart transplant. That's why all the time we're talking about timely referrals and timely addition to a heart transplant list. That's a lot of times what I do in the community is talking to a general cardiologist and a primary care doctors to make sure that they understand that the best time to have a heart transplant discussion is when we are in the office and you have limitations in your daily living, but you're not required to go to the ICU. I always tell my patients, you never want to be status 1. That's the highest priority. It means you're attached to too many machines and the likelihood of survival is days and very low. If we get a heart transplant for you, the likelihood of recovery is also lower because it will take you a lot longer to recover when you go from machine to a heart transplant. A lot of times you want to be at a higher status, but not the most urgent status. Statuses are divided into 7 different categories. 7 is very easy. It means you're temporarily inactive. It means you're on the list, but we're not going to take an organ for you because we're dealing with something, with some issue with your health that we need to resolve before you get active on the list. And then I told you status 1 is the most highest priority, status 2 less priority, status 3 less priority, and then 4 and 5. And again, nowadays we're rearranging that list, making sure that the sickest people get the highest priority, and it's always an evolving process. How we rearrange this list is a group of professionals, not just cardiologists, not just surgeons, but patient representative nurses get together every month, review the outcomes, making sure that we're looking at the nation as a whole and resolving the access to heart transplant issue and also urgency. And that's how we make this determination, who gets what type of acuity. Donor selection. You will spend a lot of times at the end of this month talking about what happens after you get a heart transplant. And the only reason I put this here is to underscore several conversations that you will likely have with your provider before getting on the list or at the time getting on the list. So donor pool is limited. There's only so many donors out there. There are only so many good hearts out there. And obviously the amount of people who need a new heart because of devastating of amount of heart failure in this country, and that list is a lot longer than the donor pool. Every day we're working on trying to get more organs to more people, but we also want to make sure we do it safely, okay? There's quite a few safer considerations right now to get your organs that way before would not be used, but they're great organs from a very quality donors. So I'm going to touch on several points real quick because most of the patients on the pre-transplant side will be asked about those considerations. And hopefully I'll clear some for you. So once you have this conversation with your coordinators, it won't come as a first time. I'll tell you about a few here. Let's go one by one. Something that I'm sure you've seen by now in New York Times, a big article came out about donation after circulatory death. Unfortunately, we know the declaration of brain death is very complex, but yet all of us are following very rigorous protocols. If you don't meet a full determination of brain death, but a consilium of doctors and nurses, including your family as well, knows and been proven that if we were to withdraw support, you're not going to be able to survive. You will pass regardless of what we do. That's called donation after cardiac death. Then when we make sure that the heart stops, what we proved through the years around the world that this type of donation should be always considered because those heart can serve a great purpose for those patients in need. And that's where donation of cardiac death comes through. We do get a special consent for this. We a lot of times walk you through the process, how this donation will happen. And that's important to know that a lot of times you will be offered this option. And the goal for this is to make sure that we utilize organs that otherwise will be discarded after a patient's death, although there are very good organs. Second one is we get new tools, we get new machines. Once you get your heart, and let's say that heart is far, far away, and usually I would normally, like 10 years ago, I'd have only 4 hours to get that heart into someone's chest. It means that I have to fly, get the heart out, put it on ice, and bring it to the patient. We're very excited right now because we have newer technologies, and those technologies help us not even stop that heart. That heart does not have to go on ice, and we can continuously feed that heart with blood before it comes to our recipient. This helps us go into farther territories. You know, you've seen on the news, there's a team that went from Nashville all the way to Alaska, got a phenomenal heart there, implanted that heart, and patient done phenomenal. So this is a beaten heart, a heart in the box. A lot of times you'll be getting a special consent for this. And the last one that I'll say here is another one that I approach our patients routinely about. I'm sure you've heard about all the advances in hepatitis C treatment. 10 years ago, 20 years ago, if you have a hepatitis C donor, you're most likely, or 99.9% will transmit the disease. That's why we did not know how to treat it, and we would normally discard a very good organs and otherwise healthy individuals. Nowadays, we know that we can eradicate hepatitis C in 99.9% cases. And that's why a lot of times, most of the, if not all, organ transplant programs in this country will offer you a donation in a patient who has hepatitis C. Again, it will be a great heart. The only problem with the donor will be that they will have hep C. And most of the time, it takes us about 6 weeks to treat the hepatitis C before it does any type of damage whatsoever. You will not develop the disease. We'll just identify the virus and we'll kill the virus with neurotherapies. Those patients do phenomenal. This is the outcomes. The outcomes of hepatitis C donors are just as good as those who do not have hepatitis C. So that's another consideration that you will be faced with at the time of pre-transplant workup or getting onto the list. I know it's a lot, and it's about 45 minutes of our discussion. What I just wanted to tell you is that, as you've seen, we're still debating in our communities, what is advanced heart failure? I want to tell you that if you as a patient need to be heard, you want to advocate for yourself and recognize when things are not going well. And a lot of times it's important for your physicians to know that you are concerned your symptoms are worsening. Do not hide your symptoms. A lot of times, more symptoms up front will help us make timely decision for you. Don't wait until they get worse. Also, living with heart failure, by any means, if you've ever been told you have to accept limitations of heart failure, you don't. And nowadays, we have so many therapies for you outside of heart transplant to improve your symptoms and improve your quality of life. And again, the last thing I'll tell you, the best time to have a conversation with your doctor about a heart transplant is not when you're connected to machines in the intensive care unit. It's actually when you have limitations and you are still seen in the office. So I'm going to pause here and I'll get Glenn back and let's see what questions you guys have. And let's go through them.
Great. Dmitry, thank you. Go ahead and if you want to stop sharing your screen there, and we can open it up. So if you'd like to ask a question, simply go into the Q&A function and we'll get those fielded. If you have any comments in the chat as well, feel free. In the meantime, I've got a couple of questions I'd like to ask you about. And first off, thank you. It was very informative. Covered a lot of topics here in a short amount of time. But, I'm going to start off with one that I'm going to go right out the gate with something I think is kind of interesting. So tobacco use, I learned something today. I didn't realize tobacco use was indicated for fungal issues, right? So you want a patient to have stopped smoking for, certainly a period of time and keep with it. Obviously, we know that that's a very difficult thing. Today in so many states, cannabis is legal, whether it's on medical card or right off the counter. And so, two things. What if somebody's like, well, I have a gummy to go to sleep. I use that, it helps me sleep and that type of thing. What's your point of view around that? In the smoking side, does the fungal thing play a role or talk about that if you would a minute?
So, every type of contraindication for heart transplant did not come from, hey, we feel like it shouldn't happen. So a lot of times when we make those decisions for the guidelines, we analyze the data set. And usually the data set is a large UNOS or SRTR, a reported data for patients who, prior received this type of, intervention. So to give you an example, back in time, we were still questioning, trying to understand, is smoking okay to transplant? And now we see that the data coming out saying that even if you stop smoking for heart transplant, then you restart, you will get pretty bad fungal infection. And that's what the association comes from. So anything inhaled, all the fumes that you inhale will lead to that fungal infection regardless, whether you start vaping, whether you start inhaling burnt materials, and like in the case with cannabis. But I'll tell you, gummies are still very unsettled. So we just published a very large study out of UK. And what we found is that we used to think that cannabis does not have a negative impact on cardiovascular system. And the new study actually showed that cardiovascular mortality starts increasing as you increase using of cannabis. And it didn't matter the form. So there was a specific analysis looking whether it's a gummy, whether it's other ways to do so. So I bet you that as we accumulate more data, I know for a fact that in quite a few states where cannabis is legal, if you were, to present to those centers, there's a chance that you'll get a heart transplant. It's not legal where I am, so yes, you are not going to get a heart transplant here. But I think that the data on outcomes or your survival after transplant will help us make the final judgment call. And obviously, in 5 years, we learned that gummies, yes, they help with sleep, but they may be harming you from the cardiovascular perspective for post-transplant. This likely will be contraindication. Now, we don't see this signal. The jury's out there. I think we may.
Okay, great. Thank you. Thanks. Yeah, fascinating, interesting. Say, we've got a couple of questions I want to make sure we get to here. What if someone has heart failure? And this is a question from Tanishka. It just says, someone with heart failure, can it be maintained with pills? And I'll even say pills or some other medication other than something with such a more complex intervention.
So heart failure is unfortunately a deadly disease. And I'm going to give you a very crude statistics. So obviously, not everyone who has heart failure needs a heart transplant. And a heart transplant is reserved for someone who ends in this end stage heart failure, this progressive disease, this pneumonia that I told you, I need help. And you start needing help when you cannot be maintained with medicines, or those medicines have to be stopped. We get into conditions where the other organs start suffering despite those medicines. But even then, let's say you are on medicines. Statistics right now tell us that if you have heart failure and you just diagnosed with heart failure, and you get one admission for heart failure, 50% survival with heart failure. And you remember what I told you about what 50% survival means. It means that chance of living for 5 years in 50% cases, as I told you, is already 50%. So unfortunately, the prognosis for heart failure, chronic heart failure, is no good. But the only reason you will ever be offered heart transplant is that we determined by constellation of all those factors that the likelihood of you surviving 1 year is less than 50% chance. So that's what truly statistically determined as end-stage heart failure. Now, I do have a lot of patients in my practice. They've had heart failure for 20 plus years. They're beating the odds. And that's the goal for us. We want to keep your own heart in place as long as possible. But unfortunately, I had patients who get diagnosed and need a heart transplant month after the diagnosis. And that beats another odds of, gives you a different perspective on this 50%.
Great. Interesting. Okay, a question on immunosuppressants. I found that chart interesting as well. I hadn't seen the quite history of immunosuppressants. Are there any, immunosuppressants that are in the works that, might address some of the current shortcomings of immunosuppressants? And granted, it's a bit of a post-transplant, and we're going to get into post-transplant much deeper, but maybe if you get on a quick high level, want to answer that.
Yeah, I'm going to tell you there's a lot of in the pipeline, and the heart transplant reliving its, excitement. There's newer drugs, not just that there's newer types of drugs that are in the pipeline, and there are also newer formulations of drugs. The drugs that you can take less often, it's easier to maintain levels. And then even looking at the drugs where you don't have to check the levels, because I know a lot of you who receive a heart transplant already, you have to deal with those levels, monitor those levels. So the more you complain to us, the better, because it stimulates us to search for new solutions. And yes, I'll tell you, join that webinar at the end of the month. There will be a lot of discussions about what's in the, on the horizon for innovations in that space. But as overall, yes, we are working on a lot of new drugs to help suppress the immune system more elegantly than we're doing it right now.
Okay, great. We got lots of really great questions coming in. I'm going to keep going through those. Real quick, I'm going to make a point to get through all the questions here. In fact, if you need to drop, to let everyone know, this is being recorded. You'll get a follow-up. Anyone who's registered will get a follow-up email tomorrow with the link to the recording, as well as a link to a pre-transplant discussion guide published by Mended Hearts, as well as a link to that resource center. So stay tuned for those. Quick question. Are varicose veins related to heart health?
That's a great question. So varicose veins always need to be looked at. Don't disregard it. It can be related to your heart health. That's why you want to see the specialist. You don't want to go to any of those, pop-up clinics that can treat it. You want to see the specialist. It can be also so that has nothing to do with your heart, and it can be a venous problem on its own. So the bottom line here is you want to see the specialist. You want to see the specialist who deals not just with the veins, but who deals with the heart, and make that determination.
Great. Okay. I'm going to read this one verbatim. Can you restate your comment about liver damage and heart transplant? I know several people who have liver damage due to congenital heart surgery, and their hearts are beginning to decline.
Yep. So liver is extremely important organ in our body. Unfortunately, when the heart's starting to decline, especially the right side of the heart starts to decline, liver can be damaged because the heart is not doing a good job. And there are other reasons for liver to be damaged, whether it's a liver disease in itself, whether it's toxin medications, whether it's alcohol, and others. The statement that I made there is that if you have a significant enough liver damage that impairs liver to the point that function of it gets lost and function of it is irreversible, the likelihood of undergoing a heart transplant alone is very low. You're not going to survive. You're not going to do well. Liver is critically important in producing factors of blood production and blood viscosity. So if we were to operate on someone who has an end-stage liver damage, whether from heart failure, whether from other reasons, you won't be able to stop the bleeding because liver is not producing enough factors. In rare circumstances, you will be offered a heart and a liver transplant. And like you noted in your question, this a lot of times reserved for someone with congenital heart disease and liver damage, and in younger pediatric patient populations and in younger adults. Someone who has an end-stage liver damage in their late life with end-stage heart failure, those cases become very, very challenging.
All right. Good to know. Here's a different, not quite medical question, but I think you've certainly come encounter with it. How much roughly does a heart transplant cost, and does insurance routinely cover it?
Yep. Okay, so I'd be frankly honest with you. I don't know exactly how much heart transplants cost. I can give you an idea. So you've seen all this, a long list of providers that are there. It's quite involved procedure. Insurance is not just paying for, cost here. You have to go fly for that organ. You have to find an organ. You have to procure an organ. You have to bring it. And then forever after, you have to take care of the patient with an organ. But once the analyses like this are done on the national and international level, what we'll learn is that it's easier for insurance or for healthcare system to cover heart transplant than to continue to take care of patients with heart failure because the burden is so high. And yes, you still need care after a heart transplant, but it's cheaper to take care of patients with after heart transplant than to constantly get you readmitted, give you more devices, give you more drugs and things like this. And the last part of it was insurance coverage. Yes, insurance coverage for heart transplant is quite good. Obviously, most of the insurance will cover a heart transplant. Don't remember, insurance is more likely to deny your Entresto than to deny your heart transplant. Those are life-saving therapies. Those are select therapies. I most of the time do not remember cases when we were not able to get insurance to cover our patient's heart transplant. Yeah. Usually, patients do not have to pay for these procedures because they're very expensive.
Yeah. Well, one caveat with that, knowing so many transplant recipients myself, your insurance may direct you to specific centers. So you're given any specific insurance may say, we need you to go to, one of these centers in order for it to be covered by insurance. That's generally the only caveat I've ever seen.
And what I would tell you, I deal with that a lot with this type of situations, and situations are different in your life. Sometimes you won't be able to travel, and it will be a limiting factor. You need to go and fight for yourself back with that insurance. And if you cannot travel, you have to tell them that. And make no mistake, they will reverse that if you prove to them that if you have to travel by plane or by car farther away than the next available center, most of the time, you should be able to fight something like that.
That's a great piece of information, and I'll underscore advocating for yourself, become an empowered patient, which is our theme through all of this. So thank you. That's very interesting. We have time for probably one, two more here. First off, mental health. It's asked, has it offered to patients pre and post? The answer is yes. With a resounding yes, but sometimes it's not the easiest thing to find. I'll let you go ahead and comment first, Dr. Yaranov.
Yeah, yes. Obviously, this is not a, you're not going to, we understand that you are not going to have like a simple procedure and walk home the same day. Mental health is clearly important, and this success for post-transplant side of it. We do evaluate all of our patients with psychologists, and those patients who identify to be underdiagnosed with things like depression, anxiety. A lot of times we will refer them for help prior to transplant. Most of the time, we will find the resources to make sure this happens. We do not believe that mental health issues can be a reason to deny a heart transplant. By any means, no. Most of the time, it's just we need to make sure that we get appropriate help for you before we get you on a transplant list, and we'll make sure that you succeed after.
Yeah. Okay. Great. Real quick, have you seen in the data, is there a difference in a pediatric transplant recipient versus an adult recipient as far as life expectancy?
So the data that I presented you, that's a pool data for everyone. So I would tell you that pediatric patients, most of the time, undergo a heart transplant for a different reason than adults. And for pediatric patients, the most common reason to go through a heart transplant is a congenital heart disease. And unfortunately, congenital heart disease in pediatric patients makes the procedure is way higher risk. So the risk going into the surgery, balances the life expectancy. So when you actually start looking at those patient populations, the life expectancy is somewhat the same. Now, that being said, if you go through a heart transplant at pediatric age, and I'm not talking about sizing, I'm just talking about that you have congenital heart disease. And if the surgeons get you through this initial period, the likelihood of you doing better than average adult is better, because you have age on your side, and a lot of times those transplants that make through the initial high risk surgery do expect to live longer.
Yeah, great. Last question. It's a future one, and I think folks more than just this person probably interested in this. Can you say something about the status of of a xenotransplant, a pig transplant?
Yeah, that's way in the future.
Yeah.
Yes, as you may have seen on the news, there was several attempts to perform to transplant a modified pig heart into a human. Why we do this? Again, because there's so many patients with end-stage heart failure, and we don't have enough organs. Not because we want to have fun or we, anti-animal, because we looking for those solutions. The problem is that the genetic material of a pig is very close to genetic material of a human, but still not identical. And your immune system will recognize this as a problem and will reject that heart. So far, the heart transplant that were performed, unfortunately, by now already passed. But every time the new heart transplant from a allograft happens, those patients survive longer and longer and longer, because we have newer medicines and newer attempts how to mitigate the risk of rejection. So excuse me. main thing we're fighting with right now is ability to sustain that heart in a human body and not let human body reject it.
Okay, great. Thank you on that. On behalf of Mended Hearts and our program sponsors, Natera and Abbott, thank you for everyone. If anyone has any follow-up questions, you'll find a link in the follow-up registration email that everybody will receive following this. And otherwise, have a wonderful afternoon or an evening wherever you are. And be sure to tune in at the end of the month where we'll be covering post-transplant. Thank you.
Thank you for having me.